The NHS is in crisis. Because of COVID, millions of people have had operations delayed. Hundreds of thousands are waiting to get cancer treatment, and A&E units are now literally overwhelmed with people seeking emergency treatment for cancer, hip and knee operations. Must we accept longer waiting lists forever, or can the NHS be resuscitated and cured? This is Tice Talk. Hello and welcome to this week's Tice Talk. The COVID-19 pandemic has affected every single one of us in ways that were unimaginable just 18 months ago. But as the pandemic begins to thankfully subside, thanks to the vaccine rollout, the hidden costs of turning the NHS into a COVID-only service for this whole period are just becoming seriously apparent. We'll be talking with a cancer patient who has literally been given an early death sentence due to delayed treatment, and a renowned world-leading cancer specialist who was the first person to warn of this inevitable crisis shortly after COVID began. Now, multiple experts have warned that England is at risk of replacing the COVID crisis with a cancer crisis. More than 300,000 people have missed urgent checks since the start of the pandemic, and thousands of people's lives are in danger, having had vital cancer treatment delayed for months or even years. But it's not just cancer, is it? Routine surgery suspended for over a year, leaving millions waiting in limbo, not knowing when or whether they would even be scheduled again to have operations, and many of them in dire straits and chronic pain. It's unsustainable, unacceptable and unfair. As lockdown eases, it's only going to get worse. It's only going to get more painful. Well, joining me to discuss all of this is my friend, Dr. David Bull. I mean, David, this is possibly the grimmest discussion we've had. People in terrible pain. Just give us your initial thoughts.
It really is, and you just reading that introduction actually really brings a tear to my eye, because actually this is a travesty. It's a terrible crisis that we're in, and really I think it was a perfect storm, because the hospitals were absolutely terrified about what was going to hit them with the COVID pandemic, and of course they were woefully unprepared, as we know, with the lack of PPE and the fact they didn't have those resources, and they really felt that they were going to be overwhelmed, and at the same time they then decided that they were going to discharge 25,000 people, as we now know, to those care homes.
Despite people denying it, that's the truth.
Despite that, and of course we now know that they then sent everyone to care homes, and many of them, or some of them, had COVID, and at the same time people couldn't then go into hospital. They couldn't see a GP because the GPs had adopted what we now call total triage, so they were refusing to see them in person, but they were seeing them via Zoom or via Skype, so what we call telemedicine. And of course what this happened at the same time, the media then, the narrative was such that people were terrified.
Absolutely
so they
terrified.
didn't go to hospital, they didn't go to see their GP.
And they thought they were actually doing the NHS a favour, a service, which in a sense people were. We'd all been asked to protect the NHS at this time of crisis. But it was predictable what would happen. You can't just delay everything for months and months and months without consequences.
No, that's absolutely right. And I think that's what people have forgotten, is that those people were seriously ill and it didn't go away. It just didn't show its ugly head because, of course, people weren't seeing doctors. They weren't going to hospitals. And we are going to concentrate on two things, and I know that. We're going to talk about cancer and we're going to talk about operations. Now, you said 300,000 fewer cancer checks, and that is absolutely right. And if you look at breast cancer alone, there was something like 20,000 fewer checks for breast cancer, and I think it's really staggering that 38,000 fewer people actually started treatment for cancer. So those people have been diagnosed, but they weren't being treated.
I mean, these are huge numbers, and these are on top of the tragedy we know last year that over 40,000 non-COVID patients died years early, what we call excess deaths above the 5-year average, and they died at home. They didn't even go to hospital. So people literally were sacrificing themselves to protect the NHS.
Yeah, and also, you know, the stories this morning in the newspapers about people who've been diagnosed with, say, prostate cancer, and of course they weren't allowed to see their GPs. They couldn't have that consultation, so they may well have been given the diagnosis over the phone or via telemedicine. Can you imagine what someone like that actually goes through, the trauma that must instill? And there's a survey that was published today that shows that 65% of those patients who were diagnosed with prostate cancer feel they were treated poorly, that they really hadn't had the service that they deserved. And I know this because I've been through it with a family member, that it is a time of crisis. And what you need is to look at the whites of your doctor's eyes.
You do.
You need to talk to them.
You need that TLC, you need that arm around the shoulder, you need that understanding, that proper face-to-face care, because it's a time of, you know, deep emotion, real fear, actually.
And your whole life goes upside down. Because you don't really know what to expect. You have so many questions, and I know this from giving the diagnosis to people, that actually that people are so stunned by being given a diagnosis that there are so many questions that then open up, but you actually are so frightened and so shocked that you don't really know what to ask. And so it's really important you give those patients time, and actually holding someone's hand is vital in those moments.
Yeah, I mean, it just, you know, it's extraordinary. The number of people who must be suffering like this, feeling really scared, but actually, because of the propaganda and the fear about protecting the NHS, they were too afraid really to speak up and express their concerns, and therefore they've suffered.
Well, I think what's really interesting about this, of course, is it was about protecting the NHS and protecting the patients, because they didn't want them going into a place where there was a high risk of getting COVID. I'd argue, actually, it didn't do either. You know, it didn't protect the NHS long term, and it wouldn't protect the patients.
There was a shocking comment that actually a columnist in the Daily Telegraph said, and she wrote that, you know, she was sick of protecting the NHS. It was about time the NHS did its job and protected the sick. And that's where we are.
And let's look at operations. There are now 4.7 million people waiting for elective procedures. I mean, just that is a staggering number. And if you're one of those people, and I said to you earlier when we were chatting that actually, you know, we're very blasé with figures, 4.7 million this or whatever. But if that's you and you're in chronic pain and you can't get your operation, it's life-changing, isn't it? And these are the highest waits that we've seen since 2007. So we are in a terrible mess. And for those people, say, with needing an orthopaedic operation, say, for example, you need your hip replaced, the average wait is now something like 2 years.
I mean, even pre-COVID, the waiting list was double where it was 10 years ago. So that's proof that actually there was a real crisis in the NHS even before COVID. And we're going to be talking later to a patient, as you say, someone specifically who has really suffered during this process.
I mean, it's interesting. We've talked a lot about people expecting waiting lists, but actually those patients now waiting more than a year for surgery has gone up by the most staggering amount. I can't quite believe it. It's gone up by 21,000%. So
it's hard to imagine what that really is.
Yeah, so there were 436 patients waiting more than a year for elective procedures before this, and there are now something like 92,000 people. So where does this end? You know, what is the story for those people who are in chronic pain, who need these operations, and they're simply not getting them, and it's got to stop. And the other problem now is that people can't go to hospital. They can't see their GP, so where are they going? They're going to A&E. And we're now starting to see seasonal stuff coming into A&E, and I know that as a former A&E doctor. So people getting
normal life.
Sunburn or, you know, falling off a dinghy or whatever it is.
That's the sign of life returning to normal.
Thank goodness.
We should expect
We should. And of course you see the A&E units can't cope, and the hospitals are at 97% occupancy. You've now got this perfect storm going on where actually the hospitals can't cope, the GPs can't cope, the patients don't know where to go, and it's got to stop. And I think there are massive elephants in the room here, because no one has really talked about the fact that the NHS cannot cope. And I don't think it's acceptable to sit there, whether you run an NHS trust or whether you're a government minister, you cannot cross your fingers and hope this is going to get better. It will not.
You know, praying is not an answer. You know, there's no question, even before COVID, but what COVID tragically has highlighted is that actually the NHS needs radical reform, or literally people will die years and years early, and the cost will be hundreds of thousands of lost life years
Well, I mean, it's really interesting. I spoke to some of my friends, many who are surgeons, and they admit privately, I don't think they'll ever say it out loud, but they have said, we will never catch up. In the current system, with the way the NHS is structured, we will never catch up. And we need to be brave enough to say, OK, if we can't catch up, we need to radically reform the NHS. And how do we actually do that? Because
I don't accept that word can't. Yeah. We can, but it requires radical change.
But the caveat I said was that with the current system. Yeah. So we know the system is broken, so let's fix it.
Let's fix it. Thank you, David. Well, one man who knows firsthand the disaster that has befallen cancer patients is cancer specialist and chief medical officer of Rutherford Health, Professor Karol Sikora. He was chief of the cancer programme of the WHO and is truly a world leader in cancer and oncology. Karol, you were amongst the first to highlight last year the disaster that was befalling cancer patients who weren't being referred. How did you pick it up so quickly? It'd be interesting just to hear that story, and then where you think the situation is now, sort of 14 months on.
So way back in February, when it was beginning, I was sceptical that it was going to be serious. I kept saying it's all going to blow away, it'll be over by Easter. That was Easter of last year, not Easter of this year. Yeah. And I was wrong. And you could see immediately what was happening. Routine operations were cancelled, diagnostic tests were missed, screening programs were cancelled. So it was obvious that the first significant disease that was going to be impacted was cancer. And indeed it was. And there were about 45,000 people that still haven't been diagnosed from last year. They're somewhere in the melee of waiting lists, of cancelled operations, of delays and so on. And delay, as everybody knows with cancer, is essentially bad news in terms of outcomes.
Yeah. And so, I mean, that was then. How bad has the situation got now? What are you experiencing, hearing, sort of seeing firsthand with patients and in hospitals?
The irony with cancer, it's too early at this stage to know how bad it really is going to be. So Cancer Research UK estimate 45,000 people missing that have cancer. What will that mean in terms of outlook? You really have to wait at least 2 years before you can calculate it and see how 2020 and the first half of 2021 compares to previous years. But just as we saw with COVID, if you compared deaths with viral infection of the chest from year to year, you could see the huge blip. We'll see the same with cancer. That's pretty obvious.
I mean, Karol, we've been inundated with terrible stories from patients who either haven't been diagnosed or they have been diagnosed, they haven't started cancer treatment. They're playing very much a waiting game with the NHS. You know, as you say, all those people who haven't had the care that they deserve. And the irony is the NHS is saying they're protecting the patients. Well, if you're one of those patients, it doesn't feel like that.
No, that is exactly the problem. You know, the NHS moved into COVID mode and they took doctors away from cancer treatment departments and put them into the COVID wards to look after patients there. And this is clear not the strategy to develop. You've got to protect certain illnesses, acute heart attacks. That's one thing to protect, so people can get immediate stents, immediate surgery if they have a heart attack to renew the blood supply. If you don't do that within 24 hours, there's no point doing it at all. The damage is done. For cancer, the delay is more subtle. And it's a matter of identifying those patients that really need to be treated within 2 to 3 weeks and getting on with it. And it's the diagnostic phase that got lost in the melee of COVID. And, you know, we can't afford to do that again. And it's ending in a very messy way as far as I can see. I think we're going to be clear, but then I'm an optimist, as you know. And, you know, we've got to get the NHS back up and running fully. And to get away from all traces of COVID, we've got to be really fully operational.
Because, I mean, you know, you've, to be diplomatic about it, you know, you've had your issues with the way the NHS is run and organised, to say the least. And, I mean, clearly the issue now is one of capacity in terms of how do we get the diagnostics done quick enough, relative to the number of people that may be suffering? And then what's the capacity? How do we build up the capacity urgently in the short term and then in the medium term in order to overcome the backlog, to try and prevent preventable deaths, and then to make sure that essentially we learn the lessons and we're on top of it forever in the future?
I mean, that sounds a very good strategy. We should put you in charge. That's the thing we should need to do. But seriously, there's no doubt that the real block is diagnostics. People with symptoms are just not getting sorted out. They can't get to their GP. Some are frightened still to go to their GP. If they do, the GP can't get access to the hospital quickly. And so everything's delayed. So how do we do that? We can't build special centres in the next 3 months. It's not like that. Reinvigorating the nightingales isn't going to help.
No.
We need to use equipment we have with staff we don't have. In other words, we have to persuade people to come in at weekends and pay them.
Right.
We have to persuade operational practices to change so that for certain types of X-ray, it doesn't need to be a qualified technician that operates it. We can train a healthcare assistant to do the same job with a lot of protocols and algorithms and supervision and so on. So we can get things moving in a speeded way.
I'm sure I was about to ask the same question as Richard. You know, the point is, you're right. We have all this equipment, and I've always wondered, why doesn't it work after 5 o'clock? Why don't we run it 7 days a week, 24 hours a day? Yeah. We've got all these medics who've retired who could come back into the system. And the point is, if you paid people to do more shifts, doesn't money talk?
It does. And, you know, the private sector's there. It's sort of been used during the height of the pandemic. And it's there to be used again. You know, obviously, the politicians on the left will accuse the system of trying to privatize the NHS by stealth. But it's a great opportunity for everybody to work together. We've got enough resources in the country, enough equipment. We don't need to build or buy any. What we need to do is get it staffed properly and to look at imaginative plans. And as you say, everything shuts down at 5 o'clock. Even still, we've got to change that.
I think people will find that, Karol, truly shocking, that you're saying that we've got enough resources. It's actually the way that you essentially husband those resources. You bring them together efficiently. I mean, frankly, okay, I come from the world of business, but I would like to see this stuff used 24/7, 7 days a week until we're on top of it. I don't see why anybody should wait longer than a week. Maybe I'm being too simplistic about it.
No, and patients don't care. Survey after survey shows that people don't mind. I mean, after all, if you had to have an MRI of your knee for a ski injury, say, you'd be quite happy to turn up at 2 a.m. tomorrow if you could get it done.
Completely.
And that would be out of the way. And most people would. And there's no cars on the road. You can park your car easily outside the unit. And it would, I'd be quite happy. It'd be quite fun, really. And there's no doubt that we're just not imaginative enough about the use of expensive equipment. Now, the interpretation of the report doesn't have to be done in the middle of the night. That can wait to the morning.
Sure.
We don't have to wake the radiologist and get him out of bed, but someone has to be there, and we have to pay them to do that. But this would be a tremendous way forward if we put the same effort into the vaccination as we have into the vaccination program.
Well,
can I just, Karol, when I lived in the States, that is exactly what happened. I went for diagnostics in the middle of the night. I had no problem with it whatsoever. I got the report back, and this is the other thing, I got the report back the next day. And again, we've got these massive problems of reporting time where literally time is of the essence. And I don't understand why we're doing that.
I know, and sometimes I've seen reports 3 months later of someone with lung cancer. It's been reported 3 months. A routine chest X-ray just lay around in the
I mean, it literally
it's crazy.
it makes me sick at the stomach to think that there are resources, whether they're scanners, whether they're operating theatres, lying semi-idle, overnight or at the weekends, when actually, with better management, better efficiency, this could be used. We've got the resources. Yes, we need to husband the teams, the staff, but in reality, it does come down to money talks, and people will work more shifts, longer shifts, if they're being paid for it.
And also if they're respected and can work out imaginatively their own schedule for speeding things up.
Yeah.
They can do it. The teams can do it. And we don't. If you compare us to the rest of Europe, why COVID has hit us harder is that systems are thought to be working at capacity, and they sort of are using the old rules. But I think this is a great opportunity to change working practices, get things moving, encourage a sort of a much more can-do mentality within the NHS. It's all possible. It just requires leadership, both nationally and, more importantly, locally.
That's absolutely fantastic. We could talk all day about it, Karol, but fundamentally, you've highlighted what's needed. It's what we stand for, because basically, it's what you see on the tin. We stand for reform, and that's what's needed. Karol Sikora, thank you so much indeed for being with us on Tice Talk.
Thank you very much.
Wow, I mean, that tells a story. Pretty shocking stuff, actually.
It does. I mean, what's interesting is he's reiterated everything we've said. We have the infrastructure, we've got the resources, we actually have the equipment, we're just not using it. And we need to be smarter and reform stuff.
It drives me bonkers. I mean, this stuff is not rocket science. If you put the head of army logistics in charge of organising all of the cancer operating theatres and the specialists, and the diagnostics, it would be sorted. It really does.
And we've talked about this before, that if you have a problem, you should really, that patient journey should be seamless, that you get a diagnosis, you get imaging, you see a consultant, and it should happen quickly. And it doesn't, and it has to change.
It has to change, and I think people will be utterly astonished that a world-leading authority in cancer care is saying, we've got the resources, actually, we've got the staff, properly organised and mobilised, and actually, as we've seen, the money can be found. It's just got to be organised. Well, thank you, David. Well, we go from a leading cancer specialist to a patient, and here to tell us his story is Graeme Whippy, who is waiting for urgent cancer treatment. Graeme, it's fantastic to have you with us. Thank you so much for sharing your thoughts with David and I on Tice Talk. Now, as I understand, you've had cancer treatment already, but now you need more. It'd be fascinating to hear your story and where it's going.
Okay, Richard. Well, thank you very much for having me here to speak about my situation. So the backstory is I've got a hereditary condition called polyposis that affects my digestive tract and gives me a 100% chance of cancer unless it's been treated. So back in 1990, I had my colon, my large intestine, removed, and I've had to have regular endoscopies every 6 months since to remove polyps from my rectum and duodenum. And I've now, at the age of 58, reached the end of the road when it comes to the polyps in my rectum. Basically, there are just too many now to be removed via endoscopies. So I need to have my rectum removed and have an ileostomy to stop me getting cancer. And I was expecting to have that operation in February. But not surprisingly, it didn't happen.
Yeah, right.
I mean, Graeme, you wrote to me, and I shared your story with Richard, and that's why we were so keen to get you on, because you cannot have this operation, because the hospital is denying you treatment which you need, because if you don't get it, you will die of your disease. And I know that your consultant was so angry about the situation, she threatened to resign.
That's correct, yeah. So basically, as I say, I wasn't expecting to have the operation in February scheduled, given the upheavals over December and January. And then I got an appointment, was sent through to me in, say, March time for a consultation with my consultant at the beginning of April. And I thought, hey, this is good. It's going to be scheduled for May, June. Yeah. So you can imagine my shock when I had the phone consultation with my consultant, and not only did she say that she couldn't schedule my operation, but the fact that she was actually going to resign in protest at hospital management cancelling her surgery lists. And she was just at the end of her tether when it came to contacting her patients, literally a week or two before their operation, to say that it had been cancelled. So, she was that determined to create change. Now, actually, thankfully, she was able to retract her resignation because the hospital management backtracked and reinstated her lists.
Right.
But she said to me in a follow-up email that basically things are still really bad, though. I'm just reading from her email. Things are really bad, though. The recovery, in quotes, is mind-bogglingly slow. Lots of politics being played. The management is being very obstructive. And the fact that she says there's virtually no COVID in hospitals now, there's little in the community, very significant proportion of people have been vaccinated. And she said our lack of activity is incomprehensible to me.
And what is so extraordinary is we hear from ministers, we hear from Matt Hancock, we hear from the leaders of the NHS that, that anybody who needs treatment is being treated, and that, they're working their socks off. And yet, actually, what you're explaining, at ground zero, on the front line, is that's not only is it not true, but they are clearly actually basically not telling the truth. I mean, they are lying, either because they've been completely misinformed or because they want to mislead the public. I mean, I find it extraordinary.
It is. Well, was it Chris Hobson, who head of NHS providers, last few days has said that trusts are going full pelt to address the backlog? Well, clearly they're not, And the other thing that my consultant pointed out to me is the fact that she says that cancer is relatively well protected. It's an obvious priority. Her concern are the people who have other conditions or genetic conditions like I have, FAP, who aren't getting the treatment they need. And she says it'll be a few months before I get cancer. So I'm one of the lucky ones, really. I've got a few months probably before things reach a critical stage. But for anybody in that situation right now isn't getting treatment, they will die sooner than they should because the NHS hasn't been treating them.
And what has this done for you in terms of your stress levels? It's bad enough having a familial condition where you know these polyps will become cancerous. You know you've got to have an operation. You have no idea when it's going to happen. You have no idea where your future lies. How does that make you feel?
David, it's having an ileostomy. I mean, having an external bag is a fairly major life change, and I'm reconciled to it. It is what it is. I've got that to contend with, but also this nagging worry at the back of my mind about the state of the polyps that I've got and whether they can continue removing them. I'm actually taking the lead. I'm effectively booking my own endoscopy appointments. I'm a squeaky wheel who says I need an appointment next month, and I've been successful so far. But as my consultant said, so many people aren't like that. They are recipients of the service, and they don't have the confidence to seek out the appointments. So in terms of how I feel, it is what it is. I'm hugely frustrated. I want to get it over and done with. I am getting increasingly nervous about the state of my health. I just really hope that I can get my operation before things do get critical for me.
I mean, it sounds extraordinary. I cannot imagine what that must feel like. And I sort of want to say, well, what are the other options out there? Can the consultant go take it to another hospital, to a private hospital?
Well, I'll tell you, a friend and colleague of mine has shared with me details of a health insurance company who don't have an exclusion on pre-existing conditions. They just have a 6-month qualifying period. So quite honestly, I'm going to wait. If things don't start moving around sort of autumn time, then I'm going to have to go for it. I'm going to have to look into going private, because the alternative is that I will get rectal cancer. And after all these years of being looked after really well by the health service, they kept my dad alive until he was 87, same condition. It would be a tremendous shame, to say the least, if we fell at this hurdle.
I think this is the real problem, isn't it? That we're really caught because we want to love the NHS, we want to believe that it gives us a great service, but when it doesn't give us a great service, people don't speak out. Your story hasn't got out there. I knew nothing about it until you messaged me. Why is the media not reporting this? And why, as Richard says, why is the government blatantly lying?
Crikey. I think politicians, in fairness to them, regardless of flavour, they're in a fairly difficult position. The NHS is now venerated and revered to such a degree that they daren't touch it. I think the press are quite beholden to the government in terms of funding. They don't want to rock the boat. And quite honestly, I think a lot of people, the general public, are so scared and focused on COVID and SARS-CoV-2 that the other stuff just is completely passing them by. They've been terrified to the extent with COVID that any other health condition really doesn't impact and isn't on their radar.
It's unbelievable, Graeme. We could talk about this, and our viewers would love to. We could talk about it for ages, but sadly time is against us.
Yep.
All I can say is what is absolutely clear from this and from our previous interview with Karol Sikora is that actually the frontline resources are actually there. Your consultant is there, the operating theatre is there, but the management is not. And it's the inefficient management that needs fundamental reform. And all I can say, Graeme, apart from wishing you, all the very best from David and I, is, we are campaigning for reform. Many others are too, and we just have to keep putting our head above the parapet and keep campaigning for change. And so, look, thank you so much for sharing those thoughts. We wish you all the best, and it's just an extraordinary tale. Thank you very much indeed. Graeme.
You're very welcome. Thank you very much for having me on.
Thank you. Wow, David, I don't know whether to cry or tear my hair out in utter fury at what's going on. Those two stories, but that's, that description from Graeme is just mind-boggling.
You can see the raw emotion, can't you? And I think, I can see you're upset and I'm upset, but I think, you can see that he can't do anything about it. And this is a terrible position to be in. And it's not just patients, it's doctors too. And the doctors want to operate, the surgeons want to operate, they can't operate, the patients need the treatment. And caught in this are real people with real stories.
And real lives that are potentially, he's almost being given an early death sentence because of the incompetence of management. And that just drives me absolutely mad. Well, sadly, that's all we've got time for this week on the crisis in the NHS and waiting lists. My huge thanks to my guests, Professor Karol Sikora, to Graeme Whippy, and we do wish Graeme all the very best and hopes that he gets his operation and the attention he needs soon. And thank you very much, as always, David, for being with me. Well, join us next time to explore the pressing issues of the day with integrity, clarity and honesty. Until then, goodbye.